Our global footprint exists among 6, I would say, regional or country offices. We have approximately 300 staff across the world, based in primarily 20 countries where we are most operational. So what do we do? The what is really our programs. And here's a long list of programs. I won't read them all, but you can see that they're quite diverse. And in fact, it's missing our newest program, which is an alcohol policy initiative. So that should be added. For the programs that you see with the asterisk, data for health and women's health, you'll be hearing a lot more detail there, but this is just a snapshot of all the different things that we do on a daily basis. Next slide is the how. So we have these programs, and I forgot to mention with our programs, you'll note that they were primarily in the non-infectious disease areas, the non-communicable disease areas of public health. But we do some work in infectious disease, and certainly we're quite active during the COVID-19 pandemic. But our core focus really is on the non-communicable diseases. The how of what we do is sort of summarized here in these 4 areas. So primarily data quality, its production, its quality, its use is really critical to all the programs that we work in. And it's not data simply for data's sake. It's certainly trying to provide evidence and support to policymaking in public health so that the policies that protect the population, that serve them and their wellness are appropriate, accurate, and well tailored to the communities that they serve. Certainly, we think that communicating these policies and the data are important too. So we do believe that with the data and the policies, we also need to make sure the environment is appropriate and acceptable to the population. So storytelling along with the data and the policies is critical. And then finally, the last thing is the program management. So to implement all the programs and policies, certainly leadership, resources, experience is something that we also provide. This is not to say that there isn't huge amount of capacity and expertise in the countries that we work in, but certainly we have resources and other technical assistance that we can offer to our partners. The next slide is really just a quick snapshot of all the countries where we work. So we have provided technical assistance to governments with the invitation of those governments and partnership agreements in over 105 countries. There's a great sort of variety of depth or breadth of programming that might be involved in any one of these cities or states, or countries, but certainly a wide ranging. And a note to say that in the United States, our program in overdose prevention is exclusively based in the United States and is trying to address the horrible opioid epidemic in the United States. So that is the only program that is exclusively based in the United States. So that's a brief snapshot of where we work. I can certainly tell you now a little bit more about what we're doing in gender equity. The next slide. Before I say anything more about our programs, though, I'd like to make sure that it's very clear that I am one mere humble servant and representative of dozens of professionals in our field. And so certainly today I will be presenting the work and efforts of many epidemiologists, statisticians, analysts, program managers, lawyers, of course, clinicians, doctors, and nurses. So I just want to make sure that it's very clear that it takes many people, experts, collaborations to do the work that we do, and certainly lots of partnership. So the next slide also is a little bit of level setting. I just wanted to be clear about some of the terms that I'm referring to at Vital Strategies. We do, of course, believe in gender equality, but we also believe that the work we have to do is focused on equity. Oops, can we go back just for a moment? And then just a note, these photos I thought represented sort of the distinction. And again, many people on this call might be more expert than I am on the nuances between gender equality and gender equity. The key difference, I think, for me is to say that equity is still focused on the fairness of health and health services and rights, but also is working to correct historical discrimination and biases. So our programs are really, we describe them as gender equitable, and we are striving to get to gender equality as well. So just wanted to make sure that those terms that I'll be using were clear. The next slide also deserves a little bit of time just to say that there are differences between the use of sex and sex disaggregated data, gender and gender data. And so you'll see as the clicks go through that we talk about both of them depending on the context. Sex really is referring to the sort of the biological condition, the chromosomal, reproductive organs, external genitalia. This is what we refer to as sex, and primarily being male, female, and sometimes intersex. Gender, could someone click through the rest of the slides, please? Yeah, and you can go through straight to the gender. And then again, gender being more of a social, cultural, and psychological condition. And those are described primarily as masculine, feminine, neither, both, everything in between. And that we believe that gender may be binary and non-binary. And certainly in the community of public health, there are many other terms, cisgender, transgender. There are lots of terms, primarily in our work with data, and we are talking about sex and gender. And so you'll hear both of these terms throughout the presentation. Thank you. Next slide. So our gender equity work at Vital Strategies is manifested primarily through our Data for Health initiative. This is an established initiative, almost 8 years old currently, and there are 4 core programs underneath it. And I'll say a little bit more about them, but it's the Civil Registration and Vital Statistics, which is one of the largest ones. We have our Data Impact or Data Use program. We have a program specifically focused on population-based cancer registries. And we have a global grants program that allows us to do shorter term government initiated programs in data as well. And so most of our gender equity work will be seen through these 4 programs. On the right, you'll see that there are a number of technical and implementing partners. And again, CDC, the Global Health Advocacy Incubator, Johns Hopkins University, various UN entities, the World Health Organization, and of course, to implement our partners with ministries of health, national statistics bureaus and institutes, research centers and academics, other government entities and agencies, and of course, civil society advocates as well. Thank you. So the Data for Health initiative is also referred to as D4H in shorthand. So many acronyms in public health, which is something most of my friends and family already know. Next slide. So again, at gender equity, we again are implementing programs through existing D4H work. And you will see a few examples of those in the next slides. And the women's health also is not part of Data for Health, but is very adjacent in terms of its goals, which is really working with improving data towards policies that are protective and serve women and girls. Next slide. So I'll start here, and these are just a few samples of some of the dozens of programs and projects and activities that are ongoing every day at Vital Strategies with our partners in country. For gender equity, we are talking about how we integrate primarily data, and again, some programs are focusing on the policy side. In CRVS, for those of you who are unfamiliar with the term, CRVS stands for Civil Registration and Vital Statistics. This really refers to counting everyone, all births, all deaths, cause of death, and sometimes marriage and divorce. And this is critical because around the world, I think they think somewhere between 40 to 50% of deaths go completely unregistered. I think half the women on the globe have no legal identity, no access to their legal identity. And many births, maybe tens of millions of children, are born every day around the world and have no proof of their birth. And there are lots of consequences, benefits, access issues that this can impede without the proper documentation. So that is one of our core programs. In Bangladesh, we're working to understand what the barriers are to female death registration. In particular, there are disparities and gaps between male death and female death registration. We are doing something similar in Cameroon, working with the government there to make sure that they are including female cause of death, and as they should. And in Zimbabwe, we are working with the government to improve how the sex disaggregation of their vital statistics. Again, there may not be fundamental male-female disaggregation of data, and so we're working with the government in Zimbabwe. Next slide. In Thailand, we are working with the government there to help them improve their fundamental maternal mortality reporting, particularly with regard to cause of death. And again, there might be reporting of a birth or death, but for death, sometimes the actual cause of death is unknown or unrecorded or illegible. And so this is also a deficiency in the sense that governments need to understand better what is happening with their population. Thailand recently relaxed an abortion law in 2021. And so we are working with the government there to get a better estimation of the abortion rate amongst in Thailand. In Cambodia, we are working with the government to actually look at their ways and the types of indicators that they collect on health, and making sure that they have a gender policy approach in what they are collecting. And that is also in Ethiopia, where it's not just gender equity, but they're also looking at other minorities across the country. So those are just a few examples of what we're doing in CRVS and data impact. Again, the collection of data and the use of data, and supporting government capacity and strengthening. Next slide. We also are doing quite a bit of work to address gender-based violence. And this also refers to how information is collected, if or when it's analyzed, the quality of it, and then if it may be used to advocate or develop policies that would prevent violence against women and girls, intimate partner violence, domestic violence, and femicide in several countries. Investigating mortality by sex or gender is also important when there are violent causes or suspicious causes of death. And this is not always done. We are working to try to establish medical legal disease investigation that sort of sets up systems that can look at things that are when there is a suspicious cause of death. We also have programs that are trying to connect different sources of data. Often there's great disconnect in systems between police data reporting, emergency room, primary health care. So trying to understand all those different sources of data, put them together, analyze them, and again, feed them back to policymakers so that they can address or interrupt the cycles of violence. Next slide. And cancer registries, we are one of the very few organizations addressing cancer in the lower and middle income countries. It is often not addressed because many countries are battling infectious disease such as malaria and HIV, tuberculosis. But NCDs are cancer is the second leading cause of death globally, and many countries are not prepared or at the place where they like to in order to understand the effect of cancers in their communities. So in Cameroon, we are working to help improve women's cancers, gynecological cancers, the leading ones primarily cervical, ovarian, uterine. And that is really important and exciting work, and we're very happy to be able to do this. We also feel very, very committed to women's leadership in cancer research and the cancer registrars at the national level. And so our cancer registries program is also supporting women leaders at the global level, national level, and certainly regional levels. And then finally, one more of our gender equity projects is the working on legal gender recognition. Next slide. Often something not paid much attention to, but to have people be able to enter the health system and receive services and access. Sometimes the non-binary, third gender, or trans community do not have proper access to because of registration limits and definitions. So this is something that we're trying to work with as well. And then there's a small project or two looking at gender affirming healthcare access to and data collection for people who are seeking gender-affirming healthcare. So these are all activities, and there are dozens more that are working within the Data for Health initiative. The next one, the Women's Health Initiative, is funded separately and is a different team. And I'm very proud of this work and what I spend many hours a day focused on with my colleagues. So next slide. I wanted to set a little bit of the history just before I dive into this. This can be very redundant for those of you who've been in this field for many, many years. But for those of you who might be new to sexual reproductive health or women's empowerment or feminist issues, the sort of critical event that happened in 1994 and 1995 in our community, we often refer to as the Cairo Conference, which was officially the International Conference for Population and Development. And then in Beijing in 1995, where Hillary Clinton famously spoke at the Fourth World Conference on Women, it seemed radical at the time, but they said that women's rights are human rights. And it is obvious now to many of us, but at the time it was something kind of, shocking for people to see. But also embedded in that message of women's rights was also reproductive health and rights, and how they are linked and intrinsic to one another. So this is sort of where some of the momentum and start really kicked off. And so that was almost 30 years ago. Certainly with the UN and the Millennium Development Goals and then the Sustainable Development Goals, they actually included not only gender equality as a 2030 agenda for the world, but there were specific targets for the SDGs related to sexual and reproductive health. So next slide, target 3.7 actually, it's not there. Okay, there's another image missing. There we go. States that there must be universal access to sexual reproductive health, family planning, and education. So that was an SDG goal. In fact, there are something like 50 indicators that refer to gender equality or equity across the SDGs, integrated among 17 core ones, but 3.7 was focused on sexual reproductive health, which was very important to get included. And then in 2016 and 2018, the Guttmacher-Lancet Commission sort of revived the interest in sexual reproductive health and rights, expanded on what was said in previous forums, but also said that we needed to be more inclusive, which included talking about some of the neglected and stigmatized topics. Globally, that might be anything from abortion to adolescent sexuality, not always things that the sexual reproductive health community was addressing directly. There was, and generally still tends to be today, more comfort talking about maternal health, but that is not the full picture of what's happening in reproductive health of lives of women. And I'm sorry, I'm gonna have to move on a little bit quicker, so I will just describe the program a little bit faster. We are working in 3 countries with wonderful partners. In Rwanda, we work with the government of Rwanda and the Ministry of Health. In Makerere University in Uganda, we work with the School of Public Health as our implementing partners. And in Bangladesh, we work with the government, with the Directorate General of Health Services and the Directorate General of Family Planning, as well as our implementing partner, the International Center for Diarrheal Disease Research, Bangladesh, ICDDRB, which is a very well-known, famous research and public health organization in Bangladesh. The next slide has too many words on it, but in essence, what are we doing? We are trying to support the policies and programs within these 3 countries to have better maternal and or sexual reproductive health care, to be safe and equitable and stigma-free, and of course, ultimately to reduce death and disability to women of reproductive age. How we do that is the same model as we do in our D4H programs. It's data quality, data collection, the analysis of that use, and then of that information, and then putting the data to use towards better policy development, policy implementation, and ultimately advocacy and communication. Next slide. So again, we can click all the way through. This is just a little bit of the timeline. We assess the data. We're doing a WHO standard data quality assessments. We are trying to form action plans for government partners to actually know exactly how to improve the data quality on these reproductive health indicators. We are hosting data-focused workshops to train and build the capacity, strengthen the capacity of those who will work with the data and make decisions and program and priority funding decisions with the data. And then ultimately at the end, that little square at the bottom indicates that we are drafting policies that we would like to help our partners in country work to make other guideline, regulation, executive orders, ministerial decisions on reproductive health indicators and information. So this is not without its challenges. The next slide. Certainly when we're talking about some of the more difficult indicators, this one is an example on abortion. You can see on the right where I'm talking about the sort of pyramid of challenges, and certainly women who can access services, who are more urban, more educated, have more resources and wealth, are able to seek services where legal and allowed under different definitions. In the middle, you might get other women who may be able to afford services and seek health facilities and then get recorded into the systems. But the large majority of what we are trying to unpack and investigate is the large number of unrecorded abortions. And again, this is just one of several maternal and reproductive health indicators that we're looking at. But often the women with the fewest resources, the most rural, the most disadvantaged, are the ones who are at risk for the most unsafe experience. So this remains a challenge in all the contexts that we're working in, particularly around this indicator. Despite all these challenges, there have been some wonderful byproducts or outcomes of our work here, and that is that there's a lot of inter-country exchange, and we're very happy to connect our Rwandan, Ugandan, and Bangladeshi teams to share experiences and their findings. We have also been able to attract the interest of several other people in our broader policy work, particularly in Uganda, and looking at their reproductive health work and working with the WHO as well. And then also the work that we're doing in our field experience in the data collection can help inform and drive different conversations with partners about post-abortion care, abortion indicators in national health management information systems, and how they're being used and how they're being defined and which ones are used at sort of global level. We have discussed with USAID and WHO on different collaborative work that they're doing with country support and health information systems. And of course, the London School of Hygiene and Tropical Medicine and the WHO have been interested in some of the work that we're doing, and through various experts at Vital Strategies, we've been able to help inform and guide some of their work as well. So there have been great impacts that, large or small, I think may be meaningful in the longer term as we wind up the last few months of this program. So I don't know if this has answered all the questions about the initial topic here, but what better data means for women's health and rights. We think that greater capacity that's built in country for people to analyze their own data, make sure that they can advocate for proper resource allocations and that they understand and have the information they need to count everyone and what is affecting their people, particularly women and girls who are more vulnerable in many, many country contexts than their male counterparts. We hope this data is used to also help governments and the civil society partners keep track and be accountable towards the commitments they made towards gender equity and gender equality and women's issues. And ultimately, we hope as public health people that we help reduce preventable mortality, morbidity, injury, and violence. And we ultimately hope that there are safer, healthier lives for women and girls, and that they can live with dignity and autonomy and to be healthy and well. So we hope we're doing this through all these different mechanisms and programs, activities, and certainly we continue to be committed to this work in the future. I hope I have not taken up too much time, but the final slide is just to thank all of you again for your interest. I want to give special acknowledgement to Dr. Onakepe Owolabi, who is the former director of the Women's Health Program, Ms. Ganushka Mangara, who is our former technical advisor for gender equity at Data for Health, and Ms. Christy Friesen, who has been a huge support in pulling together this presentation today. So thank you all, and I'm happy to answer any questions or expand. And sorry, I was a bit rushed at the end there.
Thank you, Ms. Kim-Gibbons. That was fascinating. And thank you for your leadership at Vital Strategies and your passion about empowerment of women and girls in healthcare. Now I'd like to introduce GlobalWE Connect member Carrie McKean, who will moderate a question and answer session with Ms. Kim-Gibbons.
Thank you, Ariette. And thank you, Sharon, for joining us today for that thought-provoking presentation. Your leadership in the field of public health, and in particular, your efforts to advance women's healthcare across the globe is admirable. So I'd like to start off with this question. What are some of Vital Strategies' current women's health initiatives that are closest to your heart?
Well, I am a little biased, perhaps. I've spent so many years in reproductive health. So I would say the women's health program that is their newest one at Vital Strategy is probably the one that I am sort of most passionate about at this moment. I desperately, deeply care about many of the other things that we do, like CRVS and women's cancers in general, but I certainly have a special soft spot for the data-driven policy for women's health because of my particular interest in sexual reproductive health and maternal health.
Thank you. My next question relates to deep-seated cultural beliefs that impede progress in women's healthcare across the globe. How does your organization go about shifting belief systems in order to protect women's health while respecting the local culture?
Well, I think what your question is asking is actually the answer is there to some degree. It's really about the local leadership and the local expertise. So I think for an organization like Vital Strategies, we come together around the science, we come together around the data. And I think we find leadership and expertise in countries that are seeing the same things that we're seeing as scientists and public health professionals. And through our colleagues on the ground, who are the best advocates and the most expert in understanding their communities and populations, we take their lead. We follow their advice and guidance on how to do these things. So rather than be an organization from the global north, sort of trying to imply what they should be doing or not doing, we really find the local leadership and we follow their work. And again, we share interest in the science and the data. Most of the time, that is how change comes about, through finding local leadership and partnering with them.
Very good, thank you. So thinking about the United States and other high-income countries, what are some of the biggest successes in public healthcare overall and women's healthcare in particular over the past 30 years?
Well, I will go back. So I think that question for me, I've always believed that contraception is, one of the greatest life-changing happenings for women in general, certainly high-income and low-income countries. But also, I would say advances in the last 30 years, talking about reproductive health as a right is certainly a critical change in the last 30 years, as I mentioned with the Cairo conference. I would say advances in technology. I would say advances in ART, so HIV therapies are really important as well. So a number of things have been sort of, I would say women from more developed countries have benefited more from these. And some of the countries in the lower middle income countries of the global south need to catch up to experience these benefits. But I would say, yeah, for me, contraception and family planning is one of the hugest changes. That was more than 30 years ago. But certainly then talking about sexual reproductive health, maternal health, and our rights to these is probably one of the biggest changes.
Would you say the same thing about the low and middle income countries, or would your answer be different?
Yeah, I would say in so many of the lower middle income countries, there are so many challenges with fundamental poverty, access to fundamental primary health care, education, food security. There are so many challenges that people in more difficult circumstances have to deal with that I'm not sure I know the answer, but I do feel like basic primary health care, food security and education are probably more urgent challenge for some people in the developing world. So I don't know exactly. I do think what I said for the North is true, but probably slightly less true of a priority for so many women. And I'm trying to think of that, that woman in a village might be rural, might be a farmer, might not have strong literacy or numeracy experience or opportunity. It's hard to say from my perspective what is sort of the biggest success.
Mhm.
It's hard to say. Sometimes, having cellular mobile phone service, even in a remote part of a developing country, might be the biggest, success for her health and economic well-being than anything else. So it's hard to say.
Right. That makes sense. Well, thanks for your insight on those issues. Um, I now want to shift the question to you and your experience. So you have a long accomplished career in public health. Is there any advice you would give other women looking to pursue a career in your field?
Yes, do it. Come join public health. I feel that it's a very inclusive field. I always say it's a big tent and you can contribute in so many different ways. And I want people to know that you don't have to be a PhD in epidemiology to contribute. We have such an enormous range of social workers, midwives. There are so many different ways that you contribute to public health, and teachers, educators. There are so many ways people contribute. I think it's very inclusive, and there are many ways to help your society, your community, your people. So I really encourage everyone. Yes, there are technical areas to learn. Having a background in public health training and biostatistics and epidemiology and anthropology and demography all are great assets. But there are many ways that we benefit from people coming from different backgrounds coming together around a public health challenge.
Thanks, Sharon. Now, at this time, we're going to take some questions from the audience. So I'm going to ask audience members to put your question in the chat or raise your hand, and Ariette will call on you to ask a question.
Thank you, Carrie. Thank you, Sharon. That was such an interesting presentation. I really learned a lot. One of the questions that we do have in the chat here is there a marked difference between developed and less developed countries in who is delivering health care to communities in terms of training or certification?
Oh, good question. I don't know. In so many countries, well, there's a big range. So in many countries, because of the lack of human resources, financial resources, systems of community health educators, village health workers, have been very successful and are in some ways the only access to health education information, fundamental immunizations sometimes. So those are often women. They are women who are trained. They are very influential in their communities, and it's specifically around safe delivery and child health. There are a lot of women workers. Like many other countries, though, with the higher level clinical training, I think with the physicians tend to be still majority male in many of these countries. Nurses and nurse midwives, I would say primarily female, but also, have many males as well. But I would say predominantly women have those career tracks in many countries. So I would say that it's a mix, because in some of the countries, particularly the very populous ones, a lot of the community health workers are female, but they are often less highly trained than some of the more medical, physician level, clinical officer level training.
Okay, thank you. Another member question here is, in what ways do you see artificial intelligence having a positive impact on your work and the field of public health?
Wow, I don't know how to respond to that. I think AI can be helpful. I'm actually very pro technology in many regards. I think we've seen some really, really exciting changes and access to more remote populations through technology and digital health systems and mobile messaging. And so I do think that it's technology writ large has been very positive in public health, and particularly in lower and middle income countries. AI specifically, I don't know that much about to really give a good opinion, I'm afraid. In general, I think technology has been an asset, though.
Okay, thank you. We have a couple more questions coming in. So this one says, thank you, Sharon, for this presentation. From a data perspective, we are so often limited by the way that data is collected, especially in being able to look at equity in service delivery and experience of care. Have you been able to observe or work on any initiatives that are expanding on how we collect data systemically to do this better?
Yes, actually, we have a few programs in mind. This is a very good question because experience in the health system is not always a positive one for many, many people, particularly women and girls. And so respectful care has been on sort of the discussion circuits for a while. And that is sometimes characterized as abuse by health workers to community people. And this is something I think that needs to be addressed systematically, but also we're still trying to understand. There's hierarchy in many countries, spoken, unspoken, cultural or traditional beliefs, but healthcare workers tend to be more educated and have more resources than sometimes the people and the communities they represent. And sometimes the experience that the communities have through the health system are not positive and not good. So if the question is, are we looking at that? Are we trying to address it systematically? We are trying to, and we've proposed programs to actually look at this a little bit closer. There are other NGOs working in this area trying to understand how we can solve this problem a little bit better. But did I understand the question correctly? Are we talking about how people experience and sort of the inequities in the experience of health services?
I believe so. Yes.
Yeah.
I can speak up since I asked the question. I really appreciate you talking about this because I think what I was also getting at is the measurement aspect. You know, we're so limited. We can disaggregate data, but only by those fields that are collected. And we're really challenged in understanding experiences with the way that we systematically collect. So just curious if thinking about equity and trying to understand those experiences.
It is such a difficult topic. And, you know, there's so many things that the data can help us learn, right? But often the qualitative aspects, not the quantitative counting and the measuring, but the qualitative work is where we're going to hear this. And that just takes so many resources and time that sometimes it's delayed and insufficient. So it's a challenge, but I think the more of us who are looking at it and asking it, maybe things will change.
Perfect. And a related question here, in your opinion, is it a dangerous trade-off on how data collection and surveillance by the medical industrial complex work together to limit the privacy rights or even the basic freedoms of African women?
Repeat that question.
In your opinion, is it a dangerous trade-off how data collection and surveillance by the medical industrial complex work together to limit the privacy rights or the basic freedoms of African women?
Yeah, I mean, I think the question raises a really important point, which is how this data is used, for what purposes and means and ends, and how it could possibly be dangerous. I firmly believe in the work that we're doing is in service of good, in service of better wellness, protection, and health of the women, African women, Asian women, Latina women globally. But I certainly think that there are opportunities for potential misuse. And I do think that that is something that we all have to make sure that we bake into any work that we do. We do not, as Vital Strategies, as a technical assistance partner, do not use any data from national governments. It remains with them, managed, controlled, and used by them. So we do not take anyone's data. I don't know how that works for the, sort of the private systems, pharma, any of the other groups that might have access to some of this information. So I'm sorry, I'm not a very good, I don't know how to answer that quite so well because I don't know exactly what is behind some of the potential misuses and some of the dangers, but I do think it might exist.
Perfect, thank you. And finally, I think a lot of us are curious to know how you got into this career. How did you land on this work?
Well, my mother's not sitting in the room right now, but I will say I originally started in finance and I thought that I was going to be a business lady, but I found it very empty. My soul was not nourished by working in a for-profit environment. So I, as a young woman, started volunteering everywhere I could, with children, with women, all sorts of different areas. And I just realized that I wanted to spend my life doing something socially good, whatever that may be. I think when I was in the Peace Corps on the first day of work, literally the first day of work, I joined a team in Bolivia with Project Concern, which was where I was working in the highlands of Oruro, for those of you who may know Bolivia. And a child was born while I was out on my first trip on my first day. This child was born with a cleft palate to extremely impoverished family, living in a thatch roof brick house in the middle of the field. And the baby died that night when we came back we brought the family back to the hospital with us. And it was just a really harsh lesson. I also was wondering why and what happened to the other children in that family. And this woman, it was her 5th birth, but her 3rd infant death. And so that was a huge reality to me, thinking, well, I'm here to work with the cooperatives and sort of income generation with farmers and health workers, and then that reality happened. And so I think from that moment on, I really knew that I wanted to dedicate my life to public health and doing something to benefit women. For the mere circumstance of where this woman happened to live, her child, her baby did not have a chance, did not have a good chance. And I just thought that it was just socially just too unfair. And so I've spent every day since then working towards something, whether I've worked in children, I've worked in HIV, I've worked in refugee camps, obviously. So I want to work with the vulnerable and the disadvantaged and sort of make things more right for them if I can in any small way.
That is admirable. And I think you are the perfect fit for the job. Thank you.
I do love public health. And again, there are many ways, whether you want someone to wear a bike helmet, whether you want them to stop smoking outside, whether you want people to get a HPV vaccine. There's so many good things that can be done through public health efforts and resources. So I'm very happy to be in this field and expect to be in it decades more if I can.
Thank you, Sharon, for sharing your stories. Thanks to the audience for your questions and for joining us today for this fascinating conversation. We also want to thank Leah Keene for welcoming us. And as always, we greatly appreciate our GlobalWE board and Connect team for making this event possible. I'll now turn it over to GlobalWE Connect Vice Chair Ariette for some concluding remarks and announcements regarding future events. Ariette?
Thank you, Carrie McKean, for being our moderator today. We're thrilled to share that we are planning the first ever hybrid GlobalWE Connect Women's Empowerment Expo, and the date of this is March 25th, 2023. We will have an in-person panel on women's voices, storytelling, and mentorship. Our virtual sessions include topics such as global leadership, sustainable impact, health and education, and also women in sports. Join us and register on our website. We will be hosting organizations from all around the world. Harvard GlobalWE has additional opportunities for you to share our mission, including Connect Team, essay contest, programs, marketing, and membership teams. Our website has a list of volunteer openings, and we're always looking for suggestions for topics and speakers as well. As a reminder, if you're not a member or a friend of GlobalWE but would like to join us, please visit our website at harvardglobalwe.org or click on the link in the chat to register to receive our newsletter. Thank you all again for your participation and have a wonderful rest of your day.
Thank you all.